unsupported, otherwise it will drop. As you bring it here, hold it there, and the thumb towards the floor, hold it there, push against my hand, push up, 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 up towards the ceiling. So that's what you've done your impingement test, one of them. Then bring it down further, hold it there, push again. Now at this stage, if the patient is in a lot of pain, then the power testing will be a bit unclear whether it is just because of the cuff tear or it is because of the impingement as well. Can you hold it like a stop sign? So you hold it there and see what they're doing. That also gives you an idea of external rotation. If they can bring it up to there, that means they've got more or less normal rotation. Relax, and then turn it in, and then keep looking at the patient. This is your Hopkins modification of the impingement test. And if they can do it reasonably, then I ask them to put their hand on the back. Can you put their hand on the back? And see if they can bring it there, that's fine. Hold it there. I'm going to bring this away. Hold it there for me. And don't let me push. So that's what you test for your subscap. And if you're looking for internal rotation, if this patient is bringing up to here, can you bring this hand in the back as well, as far as it will go? And then compare the two internal rotations on this same side. Okay. Turn around and face me, please. Turn around and face me. Thank you. Bend your elbow. And then at this stage, ask them to do an external rotation and then see how far they will go. It's important to test the infraspinators in the maximum amount of external rotation. Hold it there. Don't let me push it in. Hold it tight. No, don't let me push it in. Hold it there. Push, 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 push. So that's looking for your infraspinators. Now, if patients can't get their hand up to the back, even if they can get it there, so you can still test for the subscap in that position. But even if they can't get it there, then that's what's called the belly press sign. So put your hands there like that. Bring your elbows forward. If the patient can't do that, that means their subscap is pretty naff. Okay? Hold it tight. Hold it tight. Don't let me push it. And that's testing for the subscapularis muscle. Again, as you all probably be aware, that it depends what, if somebody's got an instability problem, then obviously you don't need to do all those tests. So once you've got the rhythm, you do the apprehension test, and the second is what's called as a Job's relocation maneuver. Okay? So if I get you to sit there for me. So let's imagine he's got his right shoulder is the bad one, and we've done the movements actively and passively, they are full. So I get the one which is not dislocated, hold it there, then keep looking at the patient and also feel for the deltoid and see if they've got any apprehension. If they haven't, then I put my thumb at the back of the humerus and push it forward. Obviously, if the patient has got instability, he won't let you do that. And then you test on the normal side, the same thing. Hold it there, right, so, and then push it. And then push it and look for the apprehension. If apprehension is positive, you can do the Job's maneuver in two ways, either lying down or I'm comfortable with the patients even sitting in this position. So what you do is bring the arm forward, put your hand not on the humeral head there, but over the proximal shaft. And I'm applying a constant backward pressure, so trying to maintain the humeral head into the socket laterally, and then bring it into an external rotation. Most of the times, as long as they haven't got a very unstable shoulder, that apprehension will be lost, and that's what the Job's relocation maneuver is. One other sign that often one looks for it in an instability is the Sulka sign. It's a very subtle sign. Sometimes it can be present, sometimes not, especially if you've got muscles like this, then it can be a bit difficult. Can I get you to stand up? And the easiest way to do is to lean forwards a bit, like so, and then relax now, let it dangle. And once it's dangled, then you sort of try and see if you can sublux it any forwards. If you're doing an instability shoulder surgery, there's one test that has, a sign that has recently come up, which is called as the Gagey hyperabduction sign. What it suggests is that the patient has got some hyperlaxity in the glenohumeral joint, and you may need to consider a capsular plication as well, along with the Bankart repair. The way to do it is you obviously examine the normal shoulder first, and then put your hand on top of the shoulder, so essentially preventing any scapulothoracic movement